Good morning, all. Presenting on behalf of Medicine 5. The outline of the history examination go in the order. Presenting Mr. X, 52-year-old gentleman, is an electrician from Odisha. He presented with 20-day acute history of fatigue. And 10 days ago, he had a fall with resulting in loss of consciousness. It was unwitnessed, so we can take it as a probable seizure because of the associated history. Then he also, after that, in last 1 week, he had altered behavior. He apparently well 20 days ago, he developed this generalized weakness and feeling unwell from the 1st of March. On March 9th, he had loss of consciousnness when he fell down in the bathroom. After a few hours, he regained his sensorium, but it was like he received therapy in the hospital, and post-discharge, he was all well for 2 days. And again, it changed. He had a new onset behavioral changes. He started attending religious meets. He believed that he was the head of the meeting, and he was agitated. He was swearing at his relatives, and he reported relatives reported he was having auditory and visual hallucinations. There was no history of fever or headache, no vomiting or neck pain or loose stools, no history of mood symptoms or obsessive symptoms prior to the event, no history of drug intake. At the time of the loss of consciousness, his serum sodium was noted to be 105 from the previous hospital records, and he was treated with 3% xylitol. After discharge to the home, he developed a new onset altered behavior, and he came to see MC for further management. Past history is known hypertensive, 10 years. There's a history of optic neuritis in both the eyes, which he was adequately treated with steroids, and currently is asymptomatic. 2 years ago, he's developed diplopia with a lateral rectus palsy. So that the diagnosis of considered as an empty cellular, for which he also defaulted therapy. Personal history is an occasional alcohol consumer. He's converted to vegetarian diet for the past 4 years. He's currently working in an ashram recently. Normal bowel and blood habits, no history of psychiatric illnesses, malignancy, or TB in the family. So on examination, he was conscious. He was not oriented to time, place, and person. His vitals at presentation was blood pressure was 130/70. He was tachycardic 110 with a regular pulse. Respiratory was 18 with saturation of 98%. On general examination, there was no pallor, icterus, clubbing, lymphadenopathy, or pelianemia. Thyroid was not enlarged. There were no signs of liver cell failure. Systemic examination, heart sounds were normal. There was no additional sounds or murmurs. Breath sounds were equal bilaterally, and no added sounds. The abdomen was soft, tender, non-tender, no mass for palpable, no organomegaly. His neurological score was about 28. His speech was incoherent and it was inappropriate. He was able to comprehend the words, and there was increased word output with each responses. His memory was intact, and there was auditory hallucination in his thoughts. So his cranial nerves, his pupils were equal and 2 millimeters, and it reacted to light. There was no obvious deviation of the angular growth. Motor system bulk was normal. Power was at least 4/5 is restlessly moving the limbs. There was no involuntary movements. Reflexes were not reliable. Planters were bilateral flexor. Gait was normal. No neck stiffness. Skull and spine were normal. So considering an elderly gentleman with no sudden stressors, no prior psychiatric illnesses, or family history of any other illnesses, or any drug intake, had acute onset agitations with delusions and hallucinations. What are the differentials you can think of? So let's go ahead. The clinical syndrome here, the differentials can start with considering psychosis. Psychosis either can be a psychiatric diseases or medical diseases or drug intake. Next thing differential would be other delirium. There was no cognitive impairment prior to the acute event, or just a behavioral disturbance. So the pathology here, it was a very acute, subacute onset. This is over the 1 week, 1 week to 1 month of timeline. So there's a long list of differentials for medical causes for psychosis. Everything from electrochemically to the structural causes in the brain, and systemic causes from endocrinopathies and demyelination and nutritional causes. So in our patient, considering his background history, we'll rearrange the things in the sequence, which he's a vegetarian, right? Not a vegan. B12 thiamine deficiencies, and because of absence of fever, considering endocrinopathies, and because of the 1 week short history, vascular events are also possible, and hydrocephalus, and lower down the differentials in the absence of fever, infections and autoimmune. So his investigations, he was anemic, hemoglobin of 9.8 with a microcytic with a normal REW. Total count was 7,700 with normal differentials. Platelets were 2,55,000. LFTs were normal. Sodium was 131, mild hyponatremia with a high urine spot sodium. Potassium was 4, bicarb was 17, acidosis was there. Urea and other electrolytes, calcium phosphate, magnesium was normal, and TSH was 1.59, which is it's in the normal range. So initial investigation, the CT brain was done to be normal. Evidence of inflammation, the CRP was low. However, the CSF was done, which was hemorrhaging. The cells and the protein and the glucose were in normal limits, not suggestive of a meningoencephalitis. His other cultures, expert and cryptococcal antigens were negative. Systemic infections like blood-borne virus skin and syphilis ELISA were negative. Heavy metal screening was also negative. Autoimmune encephalitis panel, non-communal panel, considering paraneoplastics are also negative. So this is one picture which helped us to link the diagnosis to finally enter. So this is on the left side is the picture where he's standing, that was over 1 year ago, and the one onto the left right side is the one which is taken during the hospital stay. So if you look at his facial features, there's a mild coarseness in the features. So considering that, with the TSH of 1.59, we went ahead with MRI. MRI has shown an empty cella with a small lesion in the anterior pituitary. The lesion is yet to be characterized, probably a microadenoma. So because the empty cella and previous history of empty cella 2 years back, he had a past history. And going on with the other pituitary hormones, his TSH was 1.59 with a low T4 FTC, so it's inadequate response from the central cause itself. Even the testosterone was low with a low FSH and LH. IGF-1 was normal. Cortisol was low with a borderline low ACTH. Summarizing, is an elderly gentleman with a new onset behavioral disturbances in personality change, and there were delusions and hallucinations. He has hyponatremia with renal loss, and the pituitary hypofunction and thyroid, gonadotropins, and adrenal insufficiency. So here we have a hypopituitarism. The differences for pituitary lesions we consider here were hypofunctioning microadenoma, histiocytosis, tuberculosis, sarcoid, and IgG4. The IgG4 was normal, ACE levels are normal. So next thing was for him to get a finer cross-sectional images with pituitary protocol with dynamic images. Further, he went back home, right? He's planning to come back after some time. So what happened to him? He was started on thyroxine supplementation and steroids, and within a day or two, his symptoms are all resolved. And he's been reinforced about the hydrocodone stress protocol in the event of acute stress. How does this psychosis is relevant in a person with hypopituitarism? So far, there's no proven theories, just hypothesis from one Krishnamurthy et al. In 2013, where they probed into the brains of schizophrenic postmortems, where there's changes in the hypothalamus pituitary axis, and those hormonal changes into the CNS cellular metabolic and electrolyte changes. So another way is the next step of the hormonal changes will at metabolic level, sodium can be low, glucose can be low, thyroid, hypothyroidism, adrenal insufficiency. In chronic changes, the growth hormone deficiency also can cause altered behavior. So there are few case studies which have been reported over the years. All of them, the cause being a patient coming with a psychiatric inpatient and found to have pan-hypopituitarism. The cause for the hypopituitarism may be different in different patients. So this is one patient in African-American male where he was came with complaints of schizophrenia. He was admitted, but he continued to worsen even on antipsychotics. Then medicine was involved and he was evaluated. His endocrinopathy was noted, and after starting on the hormonal replacement, his symptoms are all resolved, and his insight and judgment and reality sense has come back. Another patient, similar this thing, he was also he is a known person with hypopituitarism for an unknown etiology from a long back. But however, he developed these auditory hallucinations and delusions, for which he was taken into mental health care services. But however, the medical history was not available at that time because there was no access at that point of time. So when they realized that this unknown etiology was there, they, for completion's sake, when they looked into syphilis, there was also a possibility for the hypopituitarism. This patient has come as neurosyphilis. So a syphilis can directly affect the pituitary organ, causing hypophysitis and cause pituitary hyperfunction. Also, it can cause neurosyphilis directly affecting the brain organelles, causing psychosis. Another case of acute psychosis presenting as hypopituitarism. This is a patient with a macroprolactinoma, defaulted therapy going on. Yeah. So take-home points: a late onset elderly person with acute psychotic events without a family history are more likely to be an organic etiology rather than a psychiatric events, and most of them are completely reversible with hormone replacement. One thing when I was reading one of the cases, I felt like thing I should let it out. A patient with panhypopituitarism can have multiple neuropsychiatric manifestations, and one extreme case of it is acute psychosis. But it's this presentation may not be immediately. It can be after a prolonged period. Let's say, for example, somebody has a postpartum hemorrhage, and 5 years down the line, they've come with some psychosis. We may not have the history of Sheehan's or pituitary apoplexy at that point of time. So, but it can be completely reversible just by giving hormonal replacement. This is just a thank you, Aishwarya. Thank you.
How did you think, what made you think of panhypopituitarism? Is it because of the history of the genetics or with that facial features of
TSH was normal, and
how
after
do you think of sending other hormones, or how you?
What is the T4 FTC?
T4 FTC was low. T4 was 3.1 in FTC. So why it was?
First only.
No. The first is only TSH was done. Screening TSH was normal, but however, when we reached the end point where we did not have a diagnosis, at that time somebody has put forward that there was an empty cella in the past history. Then they repeated the T4 FTC, and clinically also the facial features compared to the previous 1 year back, there was changes. Right now, the images may not be very clear, but that point, so that's how they went into the T4 FTC and then the subsequent hormones.
Thank you. Thank you all. It was all your presentations were very good, but today I think after a long time we've had an